Yes. Good evening, colleagues. Our speaker for tonight, Dr. Madua, our moderator, facilitator, Dr. Segole. Welcome everyone to this evening's clinical care webinar. This is a very important topic, and equally, I think it's going to be a very exciting session. Last week, we discussed hypertension in COVID-19. Today, we are looking at hypertension's body, diabetes. Both conditions are very important. Welcome to the clinical care webinar. Today is the 23rd of November. Remember, we host these webinars every Tuesday, and we just want to thank you for continuing to join us every Tuesday. And we really hope that you are able to get maximum value from these particular sessions. Just to remind you that the reason why we continue to engage, clinicians to come and teach is because we want to improve patient care. We want to share clinical, resources that are evidence-based, so that we can enhance your clinical practice. So eventually we want to see the way you manage patients changing and improving, getting better, such that you become competent in different areas of care. Just to remind you of a few things, do share your questions through the Q&A section of this platform. But do continue really to give us feedback and comments via your chats. Remember, for you to get your certificate, you have to attend at least 60 minutes. It's as per the regulations by the HPCSA and the other councils. If you have inquiries about your certificate, please send us an email at info@clinicalcareplatform.com, but you can also visit our websites for some of our contact sessions. Just to remind you that we are working hard to make a number of training programs to be available. I'll be engaging Dr. Madua as well, after here on some of the key topics around diabetes, hypertension, and some of the medical topics that maybe we need to make available to you. Remember, it takes a lot of resources and time to maintain this platform. So we really want to encourage you to really reconsider and join us and be an official member of the platform, so that you can also get these value-adding services. Remember, these webinars are free. However, in the new year, for you to get your certificates, you would need to be a member, but members are also eligible for quite a number of free courses, as you have seen already, and also quite a number of discounts when it comes to some of the paid programs. So yeah, so please, this evening session is quite important. I've looked at the presentation and the kind of knowledge Dr. Madua wants to share with us. Please, be patient. I think that the session might be longer than expected, but I think it's going to be a great value add to all of us for this evening. So I'm going to hand over to my colleague, Dr. Segole, who is our usual moderator, to then introduce today's topic and also today's speaker. Dr. Segole, thank you.
Good evening. Thank you, Dr. Mawela. We really appreciate the platform once again. And we still urge all attendees to consider being a member of this platform for those benefits that we have said, and more education and more information. Yes, indeed, yet another exciting night. It's exactly 18:05. The number of attendees is 177, and you all know the house rules, and we are live on our clinical care platform. Last week, we had a wonderful session on hypertension and COVID with Dr. John Masina. And tonight as well, we, the clinical care platform, we bring to you live another yet exciting informative session on COVID-19 and diabetes. We all know even before the COVID-19 pandemic, diabetes was recognized to be one of the most leading causes of illness and death worldwide. And according to the recent articles penned by the leading experts in internal medicine, endocrinology, and metabolism, published in the South African Medical Journal, Diabetes and obesity has accounted for at least 43% of all death in 2012. That's quite high, compared with 33% of death from HIV and TB combined. But today we're not talking about diabetes and obesity. We're not talking about diabetes and HIV or diabetes and TB, but we're talking about diabetes and COVID. And the question is, do we know what the figures are with diabetes and COVID-19 in terms of severe illness, hospitalization, complications, or even death thereof? To unpack it for us or to break it down for us this evening, it's a friend to our platform, Dr. Matamela Madua, who is a specialist physician, did his MBCHB at Medunsa. He's the head of clinical unit of internal medicine at Ferreira Hospital in Mpumalanga province, and he currently practices in private practice at Mediclinic Nelspruit. Dr. Madua, we thank you for your time. Please do the honor of educating us. Thank you so much. We hope this session will last for an hour and a half. Thank you. You may share your slides.
Okay. Thank you very much for the opportunity. Am I audible?
Yes, you are very audible. You may proceed. Thank you.
All right. Thank you very much to all the organizers for the opportunity to give this presentation. Without any further ado, I would just move straight to the presentation, and then we can then have some fun on this serious matter of diabetes and COVID. So I just want to see if the slides are being shared. That's okay now? All right,
Yes.
those are just the introductory parts. The presentation.
You may switch off your video, Doc. Thanks.
Okay, thank you. We'll do that.
Sure. Thank you.
All right. Oh, sorry, let me share the screen. All right. All right. So the presentation is. So I just need to, yes. So the outline would look at diabetes mellitus. We look at diabetes, diagnosis of diabetes mellitus. We look at different hyperglycemic states, and we look at how we manage COVID patients with diabetes remotely. And we look at the peculiarities and challenges in managing diabetes in COVID patient in hospital. And we would correlate between obesity and severity of COVID-19 disease. And lastly, we'll do what I like doing, which is the clinical medicine, which is the case management. We've got about, I think, 8 cases. Diabetes mellitus is a chronic inflammatory disease characterized by multiple macrovascular and microvascular abnormality that can affect our body's response to pathogens. And the relationship between diabetes and infection has always been an important concern of clinicians. Infectious diseases, especially influenza and pneumonia, are very common among elderly diabetic patients. In diabetes, hyperglycemia and insulin resistance can promote the synthesis of numerous pro-inflammatory cytokines and adhesion markers, which can exacerbate an oxidative stress and inflammation in the body. How do we diagnose diabetes in a general population? You would have symptoms of diabetes, which would be polyuria, polyphagia, polydipsia, and weight loss. And if you do a random glucose, which is more than 11 millimoles per liter, that obviously confirms diabetes. Fasting glucose of more than 7 millimole per liter. Fasting is defined as having not eaten for more than at least 8 hours. If you do an hemoglobin A1C more than 6.5%, then that also confirms diabetes. And if you do a World Health Organization criteria, where you give a patient oral glucose to drink, 75 grams in water, and you measure the sugar after 2 hours, then if it's more than 11.1, diabetes mellitus is confirmed. Or alternatively, if you've got what we call an unequivocal hyperglycemia, where random glucose of more than 16.5 millimole or more, that would actually suggest or confirm diabetes. Or any patient that presents in a diabetic emergencies, the two common emergencies would be ketoacidosis and hyposmolar hyperglycemic state. And when we look at this article, which was done in Wuhan in China, the conclusion was that diabetes has an independent risk factor in terms of mortality in relation to COVID. And we look at another article done by the New England Journal of Medicine, which actually shows the bidirectional relationship between COVID-19 and diabetes mellitus. Diabetes mellitus and COVID-19, what are the challenges? We know for sure steroids are the cornerstone of management in COVID-19. We know that autoimmunity post-viral infection or any viral infection is inevitable. We know that hyperglycemia, a predictor of death and mortality. Correlation between insulin requirement and CRP levels, it's needed. The higher the CRP is, the more insulin would be required. And we have seen a profound insulin resistance from this systemic inflammation and critical illness. And the other component is that you do have what you call an islet cell inflammation and beta cell stunning secondary to COVID-19 infection. You do have what you call an islet cell inflammation and beta cell stunning. And then SARS-CoV-2 utilizes ACE2, or which is angiotensin converting 2 enzyme receptors from cell entry, and that of the ACE receptors are expressed in the pancreas. We do know that these receptors are mainly located in the lungs, in the heart, in the GIT, and in the kidney. Hence, we would see a lot of these patients presenting either with cardiac manifestation, lung manifestation, and gastrointestinal manifestation, lastly, renal failure. So we do know that COVID can actually directly injure the islet cell and cause insulin deficiency, which will lead to diabetes. This is just a schematic representation of a pancreas, just to see where these islet cells are. As you can see that they are actually in the center. So we talk about the beta cells and the alpha cells. This is just the main focus there. If you look at the islet of lung and hands, the beta cells are the ones in the middle, and then the alpha cells. This is just the most important focus between the two. And the next slide actually just covers the previous picture where the insulin producing beta cells, which are in blue, which are mostly in the center closest to the systemic blood supply from the pancreatic arterioles. This is basically the islet cells in the middle there. And then they are surrounded by the glucagon producing alpha cells, which are the ones in orange. And then you have outside the delta cells, and you also have the other cells, the PP cells, which are also in green. So in terms of diabetes mellitus and COVID-19, we know for a fact that diabetics would suffer significantly, in terms of prognosis in relation to COVID. So they have poor prognosis as far as COVID-19 is concerned. And patients with diabetes have a more severe inflammatory response and lung infiltration, which contributed to their poor prognosis, as you can see from that article from Wuhan. And the same article also states that 84 of these patients were seen in that article, 29 had uncontrolled plasma glucose level and required insulin therapy. This is a busy slide, but the most important part that you just need to focus on is on the result. And on the bottom part, we basically looking at the body mass index, and we're looking at the diabetes as well, and those that had complications in relation to diabetes, they suffered severe disease. And when we look at this article, which was from the Lancet, which also looked at both type 1 and type 2 diabetes mellitus, and the conclusion was that these two conditions still, if you have both of them, you will suffer severe disease from COVID. And we look at this other article from Diabetes Metabolic Reserve, also conclude that diabetes, if you do have diabetes, you are more likely to progress to severe COVID-19 infection. Mortality in COVID-19 in relation to HbA1c. Just to lay some fundamentals, the HbA1c is a test that we use to monitor the diabetic to see if they are controlled. So ordinarily, we would expect most diabetics who are controlled to have an A1C less than 7%. So as you can see, the higher the A1C, the higher the mortality, in relation to COVID. And the lower the A1C, the better the prognosis. So the diabetic presentation in COVID-19, it can be actually in different forms. You could have asymptomatic hyperglycemia, you could have symptomatic hyperglycemia, you could have diabetic ketoacidosis, you could have hyposmolar hyperglycemic state, or you could have severe insulin resistance. So factors to be considered in relation to diabetes management in COVID-19 on an outpatient basis. The most important part is that we need to understand that there is this state of high inflammatory response from the COVID and the diabetes itself. So ordinarily, we know that the insulin requirements are going to be high. And then we know for those that are taking medication like sodium glucose co-transporter 2 inhibitors, we actually need to discontinue because then it poses a risk for developing ketoacidosis. The sulfonylureas as well, they need to be discontinued because of risk of hypoglycemia. The dipeptidyl peptidase 4 inhibitors should not be used prophylactically, of course, but you can still continue with these drugs. And the GLP-1 receptor agonist needs to be used with caution because we know that normally they would actually cause nausea and diarrhea. Metformin should also be used with caution in those with nausea, vomiting, and diarrhea. So we say if there's any important note to take home from this slide is that if you fail to keep the glucose below 11.1 millimole per liter, you should start thinking about introducing an intermediate insulin. It could be protephane, it could be optisulin, which you could give it twice a day. And then of note is that the type 1 diabetes, they need to continue with their insulin, and we should be on the lookout for diabetic ketoacidosis. And we should keep a good hydration of about 250 ml of water every 4 hours. And then most importantly, there are patients that are on glucose sensors and glucose sensoring machine. Those patients, we know that we've been using high vitamin C in COVID, so we need actually to be more cautious because there is interaction between vitamin C and the sensor. When we look at the inpatient management of diabetes and COVID, we need to keep glucose at a level of between 6 and 10, someone can say, yes, surely that sounds more like a pie in the sky. It's difficult to achieve, but that is what we need to sort of strive to achieve. And we should take cognizance of the high insulin requirement in this setting of severe inflammatory response. In addition to that, we are using a very high dose of glucocorticoids in a form of either decadron or solmedrol or prednisone, whichever you're using. And we need to discontinue oral hypoglycemic agents. And we need to use, if we are using insulin sliding scale, please, we should not use a sliding scale alone. We should at least supplement with an intermediate acting insulin or long acting insulin, either given twice or once per day. We need to stop the SGLT2 inhibitors. We need to stop metformin, particularly those that have cardiac failure, renal failure, or those that have low blood pressures, or those that have developed lactic acidosis. We need to stop the GLP-1 in the setting of nausea, vomiting, and diarrhea. And we need to, be on the lookout that these patients will develop ketoacidosis. And if they develop ketoacidosis, we need to treat them as such, or if they develop hyposmolar hyperglycemic state, we need to treat them as such. So the most important point on this slide is that we need to understand that type 1 diabetes, they have really absolute requirement of insulin. It doesn't really matter if they have eaten or not. If you don't have any insulin in their body, they are going to develop ketoacidosis. So you need relatively some amount of insulin in the body to prevent ketoacidosis, regardless of whether they have really eaten or not. Those that are actually in ICU would be given nutrition either enterally or parenterally. So they will also require insulin twice a day or a sliding scale. And then if really it's quite bad, an insulin infusion needs to be started. So we know for sure glucocorticoids also do increase the insulin requirements. And I mean, we recommend that you actually give it twice a day, or if or not more than twice a day. And then what are the issues with these glucocorticoids? These are the important things, because this is what the nurses would generally call the doctor for. And we need to be patient with them and not get agitated. Mostly you're giving high dose of decadron, you are going to develop hyperglycemia. The nurses will call you for that. Blood pressure gets elevated, potassium drops, the patient develops fluid retention, or they start reporting epigastric pain, or they develop psychosis, or they just become confused. So you need to understand that that is obviously the result of the steroids, and you need to either cut down the dose. So let's just deal with this important matter of obesity. I mean, I must say, we're dealing with the triple pandemic. We're dealing with the pandemic of COVID-19, the pandemic of diabetes, and the third pandemic, which I call the pandemic of obesity. Obesity, well, is defined as a body mass index of more than 30 kg per meter square. And then, I mean, if we were to say, using the overweight range, I'm sure half of the country would probably be obese, because most people will be weighing between 25 and 29. So this is an important slide in a sense that, if you've got a body mass index of more than 35, really, in the presence of comorbidity, you are severely obese. Or if you just have obesity without any comorbidities, with a body mass index of more than 40, yes, you're severely obese or morbidly obese. So we know that obesity is associated with increased rate of death from all causes and from any other cardiovascular disease. We should be cautious about the so-called metabolically healthy patients with obesity and overweight. You know, they say it in vernacular, in Zulu, you hear a person say, fit. It doesn't really help, you know, in either way, whether you like it or not, you are obese. And these are the patients that are obese, but they don't have hypertension, they don't have high triglycerides, they don't have problems of lipids, they don't have problem of glucose, but obviously clinically, they might have some evidence of insulin resistance. So we need to be cautious about those patients because even without diabetes, just being obese, they will suffer severe disease. The relationship between diabetes and obesity, you know, we know that it doesn't matter what ethnicity you are. You know, if you actually, you know, it's a challenge for all the ethnic groups. Type 2 diabetes mellitus, well, is strongly associated with obesity in all ethnic groups. We've got more than 80% of type 2 are obese. And then we know the hallmark of this condition would be insulin resistance and high insulin level in the blood. Well, we need to also to be conscious that type 1 diabetes mellitus is an autoimmune disease. This has got nothing to do with obesity. If you're type 1 and you develop obesity, obviously that might be related to the insulin use and all the dietary requirements. So disease associated with obesity, the list is very long, but I will just sort of highlight what is more important in relation to COVID. And for example, we've got somebody that has severe obesity and they suffer from sleep apnea and they get admitted in a hospital for severe COVID. During the day, they're all right, saturations above 90 on whatever oxygen you're using. But the moment that, you know, at night where you don't use their continuous positive airway pressure machine or the CPAP machine, they tend to dip, then the saturations drop below 70%. So we need to be aware of those patients. If they are on the CPAP machine, it needs to be used at night when they sleep. And the second point would be the atrial fibrillation. We know COVID-19 is associated with a whole lot of tachyarrhythmias and bradyarrhythmias. And that we need to take cognizance of because just being obese, you're at the risk of developing all these things. And the last point that I would highlight, which would be the venous thrombosis, mean that these patients who are obese are prone to DVT as well. So, you know, in relation to or in addition to the COVID that they have, the risks are more. So the list is quite endless when you look at that. So let's look at the obesity and I don't know what's the story with the slides there. It's a bit of misbehavior. Okay, that's fine. I think we are back on the slides. So obesity increases the odds of COVID-19 patients being admitted. Just being obese, you are at risk of actually getting into the hospital. And we know that the prevalence of obesity was quite high in those that were admitted. BMI more than 35, you're definitely gonna develop severe disease. And the one important point on this slide is that 4.5% of obese patients discharged from ICU, they either died in the ward or home. So it's really important that we actually do a follow-up on this patient. If we want the battle at the hospital, we need to actually take it home and follow them up and see if they're still okay, because some of them do die at home. And we know that obesity increases the odds of death amongst COVID-19 patients. And even when we look at all the major viral pneumonia outbreaks, whether it's the swine flu, we know for a fact that those that had obesity suffered severe mortality. And I mean, this actually addresses the question as to why individuals with obesity at serious risk for COVID-19. a so-called an obesity paradox hypothesis, where underlying characteristics of the individual, which is with obesity, influence the physiological response to infection. That's one of the reasons. The other reason is that, obesity, there is an alteration in systemic metabolism, including insulin resistance, elevated serum glucose, and altered adipokines. The highlight is here that there is a low-grade inflammation in obese patients. It's chronically low-grade inflammation. There's a concept of nutrient dysregulation, which alters response to infection. And there's imbalance between omega-6 and omega-3. We know for a fact that hyperglycemia impairs immune cell function, either directly or indirectly, via generation of oxidant and glycation products. And I mean, if you were to take any message home from this slide, is that, with COVID, the issue is imbalance between what I call pro-inflammatory versus anti-inflammatory. In every aspect of life, there has to be a balance. So if you have more exaggeration in terms of pro-inflammation, then you have got an overwhelming inflammatory response which goes uncontrolled, versus where if you got a severe anti-inflammatory response, you are unable to actually balance it with inflammation. That's really the highlight. But lastly on this slide is that, the adults with obesity have the greater than 6-fold higher risk for severe COVID-19 infection, regardless of age, regardless of gender, regardless of whether they have comorbidity. So just being obese, it's really a comorbidity on its own. And this, I think I've addressed the issue of the sleep apnea. And what I just need to highlight is that a lot of the patients that have sleep apnea, they have either diagnosed or undiagnosed pulmonary hypertension, which obviously put a lot of stress with the disease lung with COVID, and the dyspnea becomes worse. Obese patients have an increased T-helper2 and T regulatory cells, which are anti-inflammatory. This I've addressed. And then there is also the next point as well, I think I've addressed. Obesity is associated with acute lung injury and acute respiratory distress syndrome. You will see in one of the case studies as we go to the cases. And I think I've covered the most important part in terms of the discussion around the diabetes and the obesity. Just to recap, is to say that before we get to the case, we know for a fact that the diabetes plus the COVID, there is an ongoing inflammation, and this high inflammatory state results in high insulin requirements. So you need to actually be aware of that you're going to need more insulin than the patient was using at home if they were in the hospital. And on an outpatient basis as well, you need to tell them to adjust their insulin accordingly. So I would go through what I enjoy most, which is the case management of these patients. We've got about case studies and case scenarios, which some of them have got questions, and I believe that there would be some poll on the questions. So let's go through the first case, case one. These are real cases. And let me just make a disclaimer to say that all of us, or most of us have looked after these patients with COVID. We have different experiences, and I'm only giving you my own experience that I've seen, over the few months that I've looked after these COVID patients. So your experience might probably be different to mine, but the main focus of this discussion relates to diabetes, obesity, and the control of the sugar and the COVID. And I am not really covering anything that has to do with ventilation. So let's look at the first case. Case one was a 31-year-old lady, and definitely had COVID pneumonia. She had no previous medical history. And sugar on arrival was 13 millimole per liter. And she had pyrexia and otherwise and sinus tachycardia. And she was actually tachypnic, and weight was 65. And the chest obviously revealed features in keeping with the pneumonia, and the rest of the examination of the system were unremarkable. And this is the CT scan. Let me just quickly, for those that are not exposed to the low dose CT scan, basically the low dose CT scan is a CT scan which we do without contrast or iodine, and we use it to assess the severity of the disease. Just to lay some fundamental rules, we know the right lung has got 3 lobes, the left lung has got 2 lobes. So we sort of quantify the pulmonary infiltrates. We give them percentages. So you work on a scale of 1 to 5, you give 1 point, and then you go to 5 to 25, and then you give 2 points. 25 to 50, you say 3 points. 50 to 75, you say 4 points. And then more than 75, you say 5 points. That's per lobe. So you would have a score, obviously, you would have, if you score, the worst score would be, 5 on the upper lobe, 5 on the middle lobe, 5 on the lower lobe, but then you have 5 on the left upper lobe and 5 on the left lower lobe. So, I mean, the total score works out to be 25, which you will work a ratio according to the score that the radiologist would have given you, and see how much of COVID is in the lung. That actually assists you from the beginning to see how severe the patient is. So I've actually cleared that. And if you can see from the first X-ray, the highlighter there, you see that the bottom of the lung, this is just COVID. At the bottom of the lung, you can see one on the periphery there, and then you can see one centrally. And you can see one as well on the lower lobes, as well on the left lung. Then eventually you then develop a score. But I want to show you the results. Look at the blood results. The random glucose was 26. The HbA1c is more than 14.7%. And then so we do have questions after that. So, I mean, the question is to say, is this, I don't know, the facilitator there, if yes, there are the questions. Question is, what is the diagnosis? Obviously, there's one answer. You cannot tick all the answers. Is this COVID-19 related diabetes? Is this patient having type 1 diabetes mellitus? Is it the latent autoimmune diabetes mellitus, which is also called LADA? Is it type 2 diabetes mellitus? There's clear-cut diabetes. There's no doubt that the patient has diabetes. You look at the BMI, and I don't know if it is time to, can they actually give us the answer? And yes, definitely, a lot of you, 75% said that this is a COVID-19 related diabetes mellitus. And then 7% said it's type 1 diabetes mellitus. And then 5% said it's a LADA. And 13% is said is type 2 diabetes mellitus. So definitely the feeling of the house is that it's related to diabetes. So we'll address that at the later stage. Let's move to the next case, the next question actually. And so what is your treatment option? What is your treatment option? This is a single choice, please. Are you going to give insulin? Are you going to give oral hypoglycemic agents? You're not sure. Let me remind you, the A1C was more than 14%. And you saw the random sugar was over 20. what would you do? Let's see what the people are saying there. The answer lies with the masses. A lot of our people said that they will give insulin, which is a very good answer there. Then we move to the next case. I think that's correct, but I'll come back to the first question at a later stage. Can we move on? And then we'll move on to the next slide. All right. The voting, we have closed the voting if you haven't voted. All right, can I move forward?
Yes, Doc, you can. Are you managing?
I don't know if the slide just got stuck, whether with the sharing of the screen.
Just click on the slide, just click once with your...
All right, the slide is, okay, let's see. Yeah, there we are. We are fine now to go.
Yes.
So obviously, as I said, that there was 32% involvement of the lungs, which I have actually given you that scoring system, which obviously this was more like a mild disease. Case 2. So let's get to case 2. 68 years old male, known type 2 diabetes mellitus on glucophage slow release, 1 gram daily, presented with severe type 1 respiratory failure. This patient required ICU ventilation, had a PO2 of 53 millimeters of mercury with an FiO2 of about 80% on the high flow nasal cannula. The random glucose was 15 millimole per liter. Patient was ventilated for 2 weeks and extubated. However, there were complications, and his glucose was controlled with insulin infusion. And these are his results. Let's see what the results are. Are they projecting there? Let's see, the slide seems to be, there we are. So you can see there that the full blood count shows the lymphopenia, which is a sign of the viral infection. The D-dimer was sky high in keeping with the COVID. CRP was 59. We look at what you call the interleukin-6, which also can be used as a marker of respiratory failure, which was sky high. So this patient, there's no question about the severity of the disease. Patient has severe disease. And we look at the, I wanna show you the A1C. Where's the A1C on this slide? Let's see the A1C. I don't have the A1C on this point, it's cut off, but the A1C was actually above 7. Then you've got the BNP, which shows that there was some component of cardiac injury as well from the COVID. And you look at the X-ray, I mean, this X-ray was before intubation. We see, can we have the highlighter there? And let's see if we can have the highlighter, the pointer. I'm just getting the pointer. All right, yes, we can see the severe disease involving the lower lobe and the middle lobe. In actual fact, also involving the upper lobes. You can see as well involving the upper lobe and the lingula, also involving the lower lobes as well. So this patient had severe disease, and we had no options other than intubating this patient. And then you can see the intubation. There's the endotracheal tube, the severe disease from COVID. But then we obviously decided to do a CT abdomen because there were some complications. If you look at the CT abdomen, you can see this is obviously anterior and the posterior. I mean, this obviously looks normal there. This area looks normal. If you compare it to the other side, there's this swelling here, which you're obviously going to tell me what it is at a later stage. And you can see it again. What is this complication? I mean, what is the complication? And we see that, I don't know if we are polling on this. We decided to do Another scan, yes, let's Paul. Yeah, there is the Paul. Good, thank you. And who are these saying that is an abscess, is a cyst, is a hematoma, or is just a solid mass? What do you say? The answer lies with the masses, as the politicians say. Our people have answers. Let's have the answers. All right, I think, yes, the answers. Let's see the pause. Well, a lot of you said it was an abscess, 43%, then 11% said it was a cyst, and 27% said it was a hematoma, and then 19% said it was a solid mass. And yes, the people that said it's a hematoma, definitely it's a hematoma, they're very right. And that was the hematoma, and which developed, this is obviously what the radiologist had said, that this was a hematoma, which obviously extended all the way to the retroperitoneum, involving the iliacus muscles and the right iliopsoas muscles. And they felt that there was gastrointestinal hemorrhage, which it was the case. And then, let's move to the next one. The patient developed weakness of the lower limbs. And then we then decided to do the nerve conduction studies, which obviously were sort of wishy-washy, axonal motor neuropathy. But what is the complication? Obviously, we can't call, I've already given you an answer. And the answer was that this patient developed retroperitoneal hemorrhage secondary to Clexane with a lumbosacral plexopathy, which is, we've seen few patients. It's not common, but we've seen few patients because of the amount of the Clexane we're giving. And we also think that COVID might be contributing to this imbalance. Case 3, 57 years old, female, known asthmatic with severe COVID-19 pneumonia, required ICU ventilation, treated with high-dose steroids, Decadron 8 milligram, 8 hourly, did get some remdesivir and Maxipin. Remdesivir is the antiviral we're using for COVID. Mind you, is being used for the elite, so it's really not available for the state patients. And this patient developed sinus tachycardia and hyperglycemia, and the sugar was 16, and there was no previous history of diabetes. And look at the, let me get the pointer. You look at the A1C. A1C is 7.6. We did agree earlier in our discussion that if you've got an A1C more than 6.5%, you are actually diabetes, as you can even see highlighted there. The sugar was 16, A1C, it's more than 6.5%, 7.6. And let's look at the insulin requirements over 12 hours. You can see 8 units, 12 units, 8 units, 10 units, 6 units. That was on the sliding scale. Sugar persistently above 11.1. And only there you achieve like 10.9. And this is what the CT scan showed. You can see extensive COVID there, you can see COVID there. And you see COVID all the way. And then we then decided that we should actually, before this, we decided that this patient should be intubated because she wasn't really doing well. You could see the endotracheal tube there. Patient has been intubated. And look at the extensive COVID in the lung. The whole lungs are almost wiped out. And that is severe COVID-19 pneumonia. But then let's go to the pulse. How would you manage these patients? Would you give Novorapids, and would you give Protephane? Would you give insulin infusion? Would you give metformin? Would you give Diagnose or glimepiride in a state facility? What would you do? Let's get the results. Let's see how we have participated on this one. Well, I think the message is getting across. We are hammering it home, and I'm very happy that 50% of the participants say that they will give insulin infusion, which is quite correct. The insulin infusion should have been what should have done on the patient. But the good news on this case was that she made it home, and then she came back for follow-up 2 weeks ago. And she stayed in ICU for 6 weeks, which is quite a lot of time in the hospital. And then let's move into the next slide. Okay, then so we go to case 4. 48-year-old lady with hypothyroidism on altroxin, which is thyroxine, 125 microgram. Her weight was 150 kg. I mean, if you work out a body mass index, surely you can see this lady, she was morbidly obese. She presented with severe COVID-19 pneumonia, required ICU ventilation, and no history of diabetes mellitus. We decided to screen her for diabetes mellitus while she was in the general ward. And we did not find any diabetes then. And then she developed diabetes mellitus whilst in ICU. And if you can actually see the A1C on admission was 5.9. I mean, within less than 2 weeks, the A1C was like 6.6%. which is just above the 6.5 cutoff of diabetes. So in actual fact, I want to engage your thoughts. I mean, did she actually develop, diabetes from COVID? Well, you certainly will give an answer at a later stage. If you look at sugar, insulin requirements, look at the insulin, sugar almost, going 15, 14, 11, 12, 12.6, and she required quite huge doses of insulin. But this was obviously, the question that I wanted to bring to you. What is the diagnosis? This question is coming back again. Well, you need to choose one answer. Is it obesity-related diabetes? Is it a new onset diabetes mellitus? Is it a COVID-19 related diabetes mellitus? Is it steroid-induced diabetes? Let's vote. Let's see what our people are saying.
Yeah, 5 more seconds.
What the numbers are saying.
We'll stop at 30 seconds exactly. All right, there we go.
Well, yeah, look, there's new thinking. A lot of, people said that 52% of the people said this is a COVID-19 related diabetes mellitus, and then 28% said it was obesity related diabetes mellitus. 12% said steroid-induced diabetes mellitus, and 8% said a new onset diabetes mellitus. And I'm not gonna give you the answer. You're gonna answer at a later stage, but let's see the next slide. So really, the question is, does it really matter as to which diabetes it is? Shouldn't the focus be on achieving reasonable glycemic control? And well, really, it's a non-issue, but we'll address it at a later stage. I don't think we should poll on this one. Can move to the next slide. The story is that she progressed into a full ARDS. She could not qualify for the so-called extracorporeal membrane oxygenation because of a body mass index. And even though she was relatively young, age did not protect her from dying through COVID complications. We're doing case 5. Case 5, is a 69 years old lady with type 2 diabetes mellitus, systemic hypertension, and obesity, and the BMI was 32. She was on massive doses of insulin, Novomix 54 units twice a day. That's just like 108 units of insulin a day. Presented with severe COVID-19 pneumonia. She had a CT severity score of 15 out of 25, which is about 60% of lung affected by COVID. And I mean, surprisingly so, she required oxygen via nasal cannula, and she actually never went to high care. And she actually received remdesivir, and she had Decadron twice. And you look at the sugar chart, which was a bit erratic, but it was, you know, you look at the 24, so you look at the 5, you've got the 5 there, you've got the 24, you've got another 5. So you've got another 22. That was a bit erratic. And this is her CT scan, extensive COVID in the lung, extensive really COVID in the lung. And then this is her result. I want to show you something on her results. I'm not so sure if it's projecting well, but it should be. All right, look at. All right, is the slide okay? I think it should be okay, but look at the most important part that I want you to look at. Look at A1C, 7.8, 7.6, 7.3, 7.1. This 7.1 was on admission. So, and the fact that with that A1C, with a high dose of insulin, in actual fact, protected this patient from actually developing into a ARDS or severe COVID-19 pneumonia. She never went to the ICU or high care. So obviously, that shows that those that have good control, they will suffer severe disease, but chances of them making it are quite high. So obviously, I want you to vote as to how were you going to manage these patients. Would you, how would you manage a glucose? Would you stop that massive dose of insulin? Would you use oral hypoglycemic agents? Would you just use sliding scale only? Would you maintain a dose and also put it on a sliding scale? I'm not so sure if the 30-second mark has elapsed, but what would you do? We're waiting for the answers. Well, I think maintenance dose with the sliding scale is the correct way of doing things, definitely correct way of doing things. And then I think the message is getting across. We are very happy with that. Case 6, 52 years old lady with obesity, weight of 130 kg, height of 1.7 meters. Look at the body mass index, 44. I mean, this is actually, if there's any other case that you can forget about from this presentation, this is the case that you need to remember. Presented with what was said to be mild COVID-19 infection, she reported fever, severe sore throat and headaches, and it was reported that she had mild disease. However, the engagement between myself and the casualty officer was that, well, she felt compassion for her because she was coming from afar and had planned that, you know, she would discharge this patient, or I would discharge this patient the following day. And she was saturating well at 98% on room air. And she presented with a history of no previous illnesses. And she was mobilizing well with no issues. So let's move to the next slide. The slides sometimes they get stuck. I don't know why they get stuck, but let's move to the next slide. Let's see. I don't know if the moderator there is not.
Use a click.
Okay.
Yeah.
Thank you. There is the X-ray. So you look at the X-ray on admission. Honestly speaking, there's no COVID here. There's really no COVID in the lungs. We were very inquisitive, and then we even moved forward to do a CT scan, and just to say, really, maybe we could not see, COVID on the X-ray. But I want you to look at this X-ray compared to. So let's look at the initial X-ray. That's the first X-ray on admission. And that's the CT scan on admission, no COVID. Well, that's the chest X-ray after admission. What happened? Look at she has developed extensive disease. You can see infiltrates vintage COVID on the periphery of the lungs. And then the question you ask yourself, but why did you keep this patient? Why you keep her in the hospital? Because she wasn't really having severe disease. We shall address and answer all those questions at the later stage. Let's look at the blood results. I mean, a CRP was, really, initially, okay, tampering with my slide, but it's okay. Let's just go back there. I just want to focus on the inflammatory markers. You look at the IL-6. And the IL-6 was 38, which was not really particularly very high according to what we were seeing. And then you look at the other aspect, which I want you to look at, where's the A1C? I need to show you the A1C. The A1C, look at the A1C, which was 5.4 even before. So there was no diabetes in her. So this is a classic or vintage example of the so-called metabolically healthy obese patients that we are supposed to be more cautious about. And I think what we need to highlight some few points here as to what we learn out of this. We need to, my slide is just moving up and down.
Hi, Doc, can you hear me?
We need to look at the.
Can you hear me, Doc?
The impact of obesity. So we need not to underestimate the impact of obesity. And we should minimize our excitement in obesity as far as COVID-19 is concerned. We need to trust our instincts, as far as obesity is concerned. We know that obesity is a pandemic on its own. Equally, type 2 diabetes mellitus is also a pandemic which deserves its own recognition. Go with the history of the patient, give the patient the benefit of the doubt. Do not say some patients are crybabies or need attention or have some supratentorial issues. I mean, we all have different pain thresholds. Treat all obese patients with COVID-19 as if they are having severe disease. And we need to tread carefully in patients with obesity. I mean, this is the highlight of this case. When we move to the case, chest X-ray after 3 months, obviously, she actually went to ICU, was ventilated and extubated, went home. And if you look at the X-ray, after 3 months, you look at the lower lobes. I mean, this area here is diseased. And what we learn is that, her story, had a good ending, but we know that in each and everything we do in life, there is a price that we pay for. She developed bronchiectasis from COVID-19. She went home without diabetic medication. She was euglycemic, at discharge. Sadly, I did not repeat HbA1c on follow-up because there wasn't any need. The sugars were fine. She is alive, well, mobile, not on home oxygen. However, the more you think that things have changed, the more they remain the same. A leopard does not change its spots. A Dalmatian will never be a leopard, regardless of the fact that it has spots. She remains with the same challenges of being obese, still unvaccinated. And I asked her, ma'am, why didn't you vaccinate? She said, doc, I was waiting for you to give me approval. And for those that know the Lowveld, we have the Kruger National Park where we have the leopard, and this is just an example of the Dalmatian that I wanted to show there. And Dalmatian dog and the leopard. You can see they're quite different, and neither of them can be one. Let's look at the case 7. A 50-year-old lady who was known with type 2 diabetes mellitus, had systemic hypertension, had obesity, BMI of 37, weight of 110, height of 1.7. She presented with diabetic ketoacidosis, severe COVID-19 pneumonia. She required high care admission and high flow nasal cannula and DKA protocol. And obviously these are the sugars post hair coming out of the ketoacidotic state. As you can see, the sugars, she's still, even after ketoacidosis, required insulin more, even supplements from the sliding scale. And these are blood results. And I want to show you something on the blood results. I think the highlight on the blood results, which I said in the beginning, that if you were probably paying attention, the higher the CRP, the higher the insulin requirement as well. And you can see the CRP was over 281. So you expect the CRP to be less than 5. This is a chest radiograph, which also shows extensive disease from COVID. And as you can see, vintage stuff, peripheral distribution, lower lobe, and that was X-ray. And then that is, so what do we learn from this case? We learned that ketoacidosis, it's a reality in diabetes. It doesn't really matter whether you have type 1 or type 2. We say wherever you work, if you're in charge of any unit or you work in any unit that looks after COVID patients, you need to know how to treat ketoacidosis. You need to know how to treat hyposmolar hyperglycemic state. And you need to have a protocol in place. But the question is that, would you give these patients steroids? What options do you have as far as treatment of COVID-19 pneumonia is concerned? Of course, you're supposed to give steroids with caution. Remember, the initial discussion was to give steroid twice a day, unless if you are very, very bored, you can give it maybe 3 times a day. This is the last slide, last case, I think. Case 8, which also a very interesting case, 69 years old, with systemic hypertension, normal body mass index, had severe COVID-19 pneumonia, also developed a new onset atrial fibrillation, required an ICU ventilation. And this gentleman really, he came back from the graveyard probably twice. His endotracheal tube got blocked twice on day 5 and day 12. And I mean, his endotracheal tube got blocked despite us trying or venturing into the so-called therapeutic bronchoscope, which was done on this patient. Even after it was done, the tube got blocked. But there's one important factor that I wanted to highlight in this case, and the important factor is that his body mass index actually played a very important role in him getting home. He made it home. And as you can see, this was his chest X-ray before he was intubated. Extensive ground glass appearance, both lungs, extensive disease from COVID. As you can see, post-intubation as well, extensive disease. He couldn't maintain, sets without a ventilator. And this is the evidence that I give to you to substantiate that the endotracheal tube was blocked for those that work in intensive care units. And those that are not ICU people, this is the endotracheal tube. We just took a picture of the bottom part. And as you will see that there are some opening, and this is the cuff which you inflate when you're trying to keep or secure the tube. So the whole tube was blocked, and that was on day 5. And even after he had bronchoscopy, therapeutic bronchoscopy, this tube as well was blocked again. And I think we were quite fortunate on this scenario. And I must say that really, how did we ascertain that this tube is blocked? That's pretty much a difficult job to do or task, because if you actually were to go with what the radiologist had said, was that, well, you would not blame them, because the request was not asking them if the tube was blocked or not. The request was to see if the tube was sitting properly. But what they actually said was that the tube was actually secured and there was nothing about blockage. And I want to show you something, and as to how did we get to that level where to say this tube is blocked. Certainly, you need some form of, before that, let's see. The answer to say how did we ascertain that tube was blocked was probably you need a bit of experience, you need a bit of being a veteran or being youth, and you need luck in terms of the timing, because the timing was correct. In both occasions, I was actually in the vicinity of the unit when I was told that the patient was not doing well. And then you need to trust your instincts, and then you need not to give up on your patients. And human beings are not like vehicles. You cannot easily write them off. And you need to strive to do better for all your patients. And death is very painful, more especially when it hits home. It is always easy when it is somebody else, somebody you know or you hear about, but when it hits home, really, the chicken come home to roost. Remember, all of us, we have been patients before. We can always be on the other side of the fence. Treat everybody the way you would like to be treated. I want to thank you, and I want to say to you, I thank you for listening to my story. And you need to remember that COVID is our modern day reality, is not a myth. And we are not sitting anywhere trying to cook the numbers. And remember, the numbers are driven by people, because somehow people think that this COVID is flying on air. It's people who drive the COVID. So if you move from here to Gauteng, you've got COVID. we will certainly give it to the people in Gauteng. And we also encourage the masses to say that for those that have received their SMSs about getting a booster, please do it before we reach the 4th wave. Thank you very much. I shall ask the facilitator to facilitate the discussion, the questions, what needs to be addressed. Over to you, Dr. Scholar.
Thank you so much, Dr. Matamela. Thank you. We really appreciate this very informative session. You audit yourselves, the cases. I wish we had more time so we can challenge ourselves. You know, myself being a surgeon, I found myself being challenged, but quite interesting. And like you said, we should always trust our instinct, and we should never write off patients. I think that's the take-home message for today. And of course, we love happy ending, and I think this is a happy ending with a very informative knowledge. Thank you so much. I do have 1 or 2 direct questions, and some of them are, the other 2 questions are related to the cases. The straightforward questions, it's from the chats and the Q&A session that do we really have to do glucose tests in all our COVID suspect patients? Do we really have to do a glucose test?
In all the suspects or confirmed cases?
All suspects or even confirmed?
Well, what we would recommend is that, well, the body habitus of the patient, it's quite important. And mostly those that are leaning towards obesity or overweight, certainly they should be subjected to a glucose test. And all these patients that we admit giving high dose of steroids, and we should actually be monitoring the glucose, because sometimes, or as you can see with the cases that I've given, you would not be able to say which one is which. Is it the steroids, or is it related to COVID, or is it just the new onset diabetes? So that would actually assist us in that regard. So we're saying that you, in the range of being obese or overweight, you got COVID, you can sort of like, what I say, forward thinking ahead, planning for this patient, because you know for a fact that at some point these sugars are going to go sky high, and you can sort of preempt them and act decisively and accordingly as and when those issues arise.
Oh, thank you.
Yes, no, thank you very much, Doc. This was a very great presentation. Someone is asking, so this retroperitoneal hematoma, how does one avoid such a complication?
Well, I would say you are stuck between a rock and a hard place. Let me just give you a background. There are those that have resources, and then they will do certain tests. There's a test called a thromboelastogram, which was just used to see whether the patients were hypercoagulable or were at risk of bleeding. We did that. I personally did that in most of my patients, but then I realized that even doing the thromboelastogram test did not assist me, because some patients bled even when the thromboelastogram was within the normal range. So it's a difficult situation. You do need that Clexane. So I'll say you're stuck between a rock and a hard place, but the chances of it happening is very, very low. So one just has to be alert on it when you start seeing a drop in hemoglobin where the patient does not have any evidence of either what we call upper GI bleed or lower GI bleed. Then you should start thinking about it. And if you look at that case, the management was that the surgeons were involved, and the surgical approach was that we would actually just wait and allow it to resolve and hope that it doesn't get infected. And that's exactly what happened.
Okay. Quite interesting. Doc, just a quick one in relation to vaccination and diabetes and COVID. They say, why do people with COVID-induced diabetes after titrated down due to hypoglycemic spells post-recovery from COVID?
What happens to it?
Yeah, I think the question is saying after they vaccinate, they seem to have some hyperglycemic spells after vaccination. These are post-COVID patients who were euglycemic at some point post-COVID, but after vaccination, they then get this hyperglycemic spells. I'm not sure if you know anything about it.
Well, what we know is that in general, we don't have much, I don't have much literature to back that one up, but it's through interactions with patients and interaction with colleagues. And I've had colleagues that had COVID, and when they actually went through a process of vaccination, some of them told me that they actually relieved the COVID symptoms. They felt like it was coming back, but that actually was just transitory. It never lasted more than 24 hours. So you would know that there is some few amount of patients that would develop like generalized, muscle aches and inflammation. And in relation to the sugar, I would not have any article to back you up on that one. But I cannot give you a clear answer on that. So I don't have article to back it up.
Yes, and then Doc, in terms of the pathophysiology, I mean, what is the theory there? Is this the virus itself, destroying the cells, or is it a part of the inflammatory response, the cytokine storm? Why would diabetes become such an important disease or co-infection with COVID-19? What is the actual relationship between these two conditions?
The most postulated hypothesis is that the virus itself directly affects the beta cells because there is receptors there.
These people are disturbing me.
Please mute.
That's what I'll be there after.
Sorry, let me mute Dr. Segole.
Okay, let me just reiterate your question for the masses to understand. Yes. So the question was that, what is the exact issue in relation to why all of a sudden this diabetes with COVID? And the most postulated hypothesis is that you have the virus itself destroying the pancreas, but there's not being enough, randomized control trial in that regard. So you need more information there. But I think from where I'm sitting, I think the more of this inflammatory response increasing the insulin requirement also play a role. So at this point, we're not sure which one is which exactly, but we know that there is multiplicity of factors that are involved.
Yeah. So I want to try and take some few hands. So maybe Kuba, Feji Tebogo, Anthony Moll, just check if your hands are truly up or it's by mistake, because I would want to take your hands. If it's by mistake, please lower your hands. In the meantime, Doc, can you address this issue? You've mentioned a therapeutic bronchoscopy, and we know that there was a lot of controversy around this particular intervention. Can you just clarify to the audience under which conditions would it be considered We know that it's not something that is easily feasible, particularly in the public sector. What is your experience with the procedure, and under what context would this procedure be considered? Thanks.
Okay, thank you. As you would know, the gentleman that pioneered, or actually that made it famous, was Dr. Emmanuel Taban, the pulmonologist in private in Johannesburg. So the procedure, it's sort of, you know, you putting a camera in the lung. You want to remove as much as mucus plug as possible. And the rationale behind that was that a lot of these patients developed mucus plug, like the one that I've shown you, which the patient that I have shown you developed mucus plug. I think that patient was in the second wave. And then I think we also had a lot of mucus plug, especially in the first wave, where, you know, you just put the patient on the ventilator and then the next thing they die. And they just don't know what happened. They just can't ventilate, or you put them on the ventilator, then you connect the ventilator, then they refuse to ventilate. Then you try and back them, and then you realize that there is resistance. But the simplest way would be that the nurses will tell you, like, look, this gentleman has got lots of secretion, doctor, lots of secretion. We just suctioning him or this lady has got secretion. That's when then maybe then you can obviously consider doing that. I don't think it should be done for everyone. There are specific patients that develop mucus plug. It's not all the patients that develop mucus plug. So I hope I've addressed that.
Yes, you have. And then I see Mukhetipule, he's a medical manager in one of the public hospitals, and I'm sure his question is all about access and cost. He saw a lot of CT scans being done there, so he's trying to figure out at what point do we decide to do it? Should it be routine in these acutely ill patients, or how is the decision made?
Well, let me answer it in twofold. One is that you would remember that I'd said that I'm giving you an account of my own personal experience. And somebody else can actually come to a different conclusion. And these are my premise of doing a CT scan on this patient. I say, one, I do it in the beginning when you come in, and I know how bad you are. Then I will know where to put you from the beginning. So I know you could have scored, my own analysis was that if you scored more than 12.5% from the CT scan, it says that 50% of your lungs are affected by COVID. So if you're sitting in the ward and then the nurses call me and say, the patient is struggling to breathe, and automatically I know that it's not something that is surprising me. I expected it. Then I will move you immediately to the next level of care, and sort of take drastic decision earlier. That is my premise. Somebody else will come from an angle to say, but well, you could see it on the chest X-ray that the patient is hit. But the rationale is that if you could actually see it clearly on the X-ray, it means that it's actually more severe than what you thought. If you're seeing it more clearly like that on an X-ray, it tells you that the patient is hit. And I'm sure on this platform, there are some of my doctors from Ferreira, there are probably doctors from all over the province, where there are structural challenges. The structural challenges would emanate from accessibility of just doing a chest X-ray, where you will struggle just getting a chest X-ray and then let alone CT. So to some of the audience, they could say, yeah, look, the CT scan is like a pie in the sky for them. But I still maintain that if you actually sort of select these patients on the basis of the severity, it sort of conscientizes you to see how severe they are. Because I tell you what, if you do an X-ray and then you don't see severe disease, you keep the patient in the ward, but you're not really sure how severe they are, then they phone you. A lot of these patients deteriorated, they died at night. And at that point, you know, with COVID, we say, once they say resus COVID, you most likely not going to achieve anything by doing a resuscitation. And somebody obviously, I'm just provoking thoughts here. I'm not saying that do not resuscitate COVID patients. I'm just saying that when you get to a level of saying resus, it's way too late. Because the moment you plan to say, I'm going to intubate this patient at this particular time, and you plan it in a very controlled environment, then you have good results. That's why I say somebody else could say something different, but I'm giving you my own experience. I mean, if I give you my own experience in my own facility there, you know, we had structural challenges in terms of getting just a basic chest radiography. So I hope that would address the clinical manager's concern. So I'm not saying that all these patients must have CT scans. I'm saying that if you actually see that this patient is severe and then you need a scan, do the scan. It will tell you more than what the X-ray says. And then you can make a decision on the basis of that.
Thanks, Doc.
You know, we have low, you know, we don't have resources at all, or we are resource constrained in the state. So that is the reality of the matter.
Yes. No, thank you. Thank you very much, Doc. Let's see if we can take 2 hands before we close. Tebogo Matlako, do you want to say something? Would you like to unmute? Your hand was up, Tebogo. Please unmute.
Hi, sorry, I think it was a mistake. I don't have any question.
You are welcome, thanks. Elizabeth? Elizabeth? Rari Motega? Do you have a question, comment? All right. Kumba? Daphne? All right, I think most of these hands are not true hands. Doc, if you can just address one issue and then I want us to close the meeting. I've seen a number of comments, you know, around the use of HB1AC to diagnose diabetes. Is it part of the gold standard? I mean, what are the strengths and what would be some of the weaknesses in using HB1AC, you know, to diagnose diabetes?
Well, thank you very much. If you look at the Society of Endocrine Diabetes and Metabolism, which are the endocrinologists in the country, they have put that as a guideline in 2016, if subject to be corrected, but that has been the guideline that we are using. So A1C can definitely be used to diagnose A1C, but I'm sure maybe I was expecting a question on the, as to say, but yeah, the A1C was 5.6 and then it's 6.6 in a space of like 2 weeks.
2 weeks.
I just need to clarify that as well, is that remember the A1C gives you actually even more information on what has happened actually for the last 2-3 weeks. So If you see your patients, when you actually reading it, you also need to take cognizant to that fact that it's also giving you, accuracy in terms of the most recent issues. Of course, it gets influenced by the hemoglobin. So, I mean, if you've got issues with low hemoglobin, the A1C might not be reliable in those circumstances. But other than that, it is a policy guideline from WHO, from the Society of Endocrine and Metabolism, and it is a policy or a guideline from the American Diabetes Association. So it's what we do. The challenge with that is that a lot of patients will come to you and say, well, I don't have diabetes. You're saying I've got diabetes from A1C. I feel nothing. My sugar is fine. I don't know what you're talking about. But remember, the rationale behind the A1C was to say, when you look at the type 2 diabetes mellitus, by the time you actually see them in your rooms or wherever you see them in the hospital, at diagnosis, you are encouraged to screen them for complications because there is that 8 to 10 years lag behind of diabetes. Hence, the A1C made us to actually pick up diabetes early and prevent complications, because majority of the type 2s, by the time you see them, they already have complications. So if you see, I think the highlight is that you see a new diabetes type 1 in your rooms for the first time, already you must be screening them for microalbuminuria. You must be screening their eyes. You must have an ECG on them. So you need to be screening them for all complications, because by the time they present, they already have complications. So that is the essence and of doing the A1C.
Great.
I hope that has actually addressed this matter of A1C. I'm not so sure if there's still any questions with regards to that.
No, that is that, Doc. And then there's just two hands. I want to try again. Felix Alberto, are you able to unmute? Felix Alberto. Nazrin Mohammed. All right. I don't think we have the
hello. Hi.
Oh, okay. Yes, ma'am. Thank you.
So I'm a professor in radiology, and I just wanted to make a comment. In COVID pneumonia, radiologically, this is the first time that we are seeing this rapid progression into fibrosis, because pulmonary fibrosis really takes years to develop. But in COVID, and we're doing a number of studies in the University of Witwatersrand, we're noticing that due to the increase in interleukin-6, that within weeks, these patients have honeycombing fibrosis, bronchiectasis. So I think that is something that everybody should be cognizant of.
Thank you very much, Prof. And what are your predictions around the long-term implications of this as part of the long COVIDs and sequelae?
Absolutely. So I think it will definitely have an influence on the lung function tests of the patients. What we found is that there's definitely an apical basal gradient. So the basals are definitely more affected than the apices in all COVID patients, even in the international literature. And unfortunately, I do feel that this is going to lead to chronic lung disease in many of our patients, because it looks like even with the steroids, etc., when we scan them 3 to 6 months later, we're still seeing the fibrosis. So this is, unfortunately, looks like it's looking irreversible at this stage.
Thank you very much, Prof, for that. Dr. Madua, would you like to make a comment on that? Is that similar to what you are seeing as well?
Yes, thank you. I think the Prof has actually made a very important comment. Remember, in the first wave, people said, look, I just get it done and then that's it, and there's a whole lot of other complications that arise from COVID. And particularly that fibrosis part, I actually been doing a lot of follow-ups on these patients, and we following them up at around 3 months. And some of them, then the radiologists would actually say, look, well, there's still evidence of plaques and fibrosis in these patients. And yes, we certainly see the very same thing that you said, that predominantly, on the bottom of the lungs, we've seen quite a lot of them. And yes, I think we just need to look forward to say it's just not only an issue of saying, yes, it's a flu, this and that. There are a whole lot of implications. I tell you what, the other thing that I needed to highlight was that there were some few cases that had gastrointestinal manifestation, where the patients presented with gastroenteritis, and obviously, for obvious reasons, they will be admitted, but with no x-rays or anything. And when we looked at those patients as well, we found out that despite them not being in respiratory distress or anything, they did have changes in their lungs already. So at the end of the day, I say whatever, whether it's an X-ray or is it a CT scan, please get some form of imaging, because there is some long-term issues here, and some of the people, get this COVID from where they work, and then if you don't have anything to show from the beginning to the end, has some serious implications as well.
No, thank you. Thank you very much, Doc. I think we really got so much from this talk. My only concern is that some of the risk factors are very difficult to manage. I mean, you spoke about obesity, and I was asking myself, what exactly, how do we deal with obesity? Because it is such a huge burden in our country, in the world. And as we grow up, all you can do is to gain weight. So it kind of like puts us in a very awkward position, because if we are failing to manage some of these risk factors, a condition like diabetes would always continue to be a huge problem globally and also locally here. Colleagues also need to be encouraged, Doc. We saw a number of your patients coming in very sick, and then finally, leaving the ICUs, coming back for follow-ups. Are you able to predict at this stage, as you see your patients, what are the good things to pick up that can tell us that this patient will have a good outcome? Because I also saw a very mild case ending up with a severe disease, but do we have one or two predictors of good outcomes on a positive? Yeah.
Thanks. I think it's a whole lot of factors, but in the main, what I actually learned that I actually could share with the audience is that the biggest challenge was the timing around when you put this patient in a specialized unit, and the timing around intubation and ventilation. And I think in my own experience, the biggest challenge was that we tend to delay the inevitable, where we drag our feet. We can see this patient, because of that ability whereby they can maintain a respiratory rate, sets at a very low PO2, and you find the patient lying with a PO2 of 40, but still looking comfortable. And it's either you have to make a decision that you either going to intubate this patient and ventilate or not. And it's about the timing. If you wait for the patient to crash, then you most likely not going to have a good outcome. And if you actually plan the intubation on the patient, I think the outcomes are sort of, other people might argue, but the outcome looks good as far as I'm concerned in that regard, where you plan that, look, this patient is hit, I'm going to intubate this patient at around 9 or 10, and then put on the life support and then do all sorts of procedures and all the SES and then what you call the ARDS protocol, then that helps. But when you wait for somebody to crash and say resus and say take the patient to ICU, it's too late. It's way too late to do anything for that patient. So we end up exposing, the staff and everyone. So we have to make a decision, say, this patient, we're going to intubate, and then when are we going to intubate the patient? Or this patient, you're doing CPAP, or this patient, we're doing high flow. And then once there's clarity in that, then it makes life easier for everyone who's working around the patient.
No, thank you very much, Dr. Madua. I really appreciate your time. I know it takes a lot of effort to prepare for talks. Also, thanks to Prof for your comments. They are very valuable to our audience for attending and staying on until this time. It means this session was of great value to you. I know we are not able to answer all the questions, but please bear with us, continue to support the platform. We also have people who are watching you live on Facebook, Doc, and they really appreciate your presentation. They've sent you lots of hearts there to show the love they have. In the words of Lifuno Malala on the chat box, Doc, he says, thank you very much, Dr. Mawela and Dr. Madua. Thank you for sharing your story, quite informative. It's quite humbling to learn that even in this day and age, striving to do the best for the patient is still a priority. Keep up the good work, and may the good Lord bless the works of your hands, Dr. Madua. I couldn't have said it better. Thank you, Lufuno. Thank you to everyone. Good evening. Have a great, peaceful night. Thank you. The session is officially closed. Thank you. Thanks, Doc.